Good afternoon, everyone. So the first abstract which I'll be presenting today is patient-derived organoids in response to chemoirradiation of locally advanced rectal cancer. This was a study done in the Shanghai Cancer Center by Yao et al. So a brief background, we know that chemoradiation forms the basis of management of all locally advanced cancers, and response prediction to chemoradiation is important for prognostication. There is an accumulating evidence which indicates that patient-derived organoids can predict drug response in the clinic. What they have done is that they have taken biopsy samples from the patient and they have done studies on that in vivo and in vitro studies in the clinic, in the labs, and they have shown that chemotherapeutic responses can be assessed by these patient-derived organoids. However, the ability of these patient-derived organoids to predict response to chemoradiation for cancer patients remains an open question. So what they did was that they took the biopsy specimens from 112 treatment-naive patients and sent it for organoid culture into the lab. Then they did pathological analysis, genomic analysis, and they assessed the response of radiation and drugs on these organoids which they had cultured. These same patients then underwent the regular line of treatment, which was chemoradiation, followed by surgery, followed by clinical and radiological response assessment. So all these patients were actually taken from a phase 3 clinical trial, the ClinCare trial, which was basically a study which was doing the assessing the addition of irinotecan to the standard line of treatment in locally advanced rectal cancer. They cultured the rectal cancer organoids and they assessed the response to radiation, 5-FU, and irinotecan to the patient and to the organoids which were cultured. So out of the 112 biopsy specimens which they had taken, 96 rectal cancer organoids were actually established and expanded, and they established a living rectal cancer organoid biobank. 6 of the samples had bacterial contamination, and in 10 there were no expansion. What they found was that these rectal cancer organoids actually recapitulated the histological features and marker expression of the original tumor tissue. And the HNA staining, the patient-specific heterogeneous morphologies were seen both in the tumor and in the organoid. Same when we see in the IHC staining, both in the tumor and in the organoid, the IHC staining patterns which were found were similar. Then the genomic analysis, when they did, they found that the DNA copy number variants were similar in the tumor and the organoid. So here we can see in this, the patient number 7 in the tumor and the organoids, the blue indicates a gain in the CNV and a red indicates a loss in the CNV. They are pretty much similar. Same applies for patient number 10. And what they found was that there was a high concordance when the purity level on the samples was high. They also generated heat maps to show the concordance between the tumor and the organoid. And they found was that there was a high level of concordance in the driver genes, blue indicating a gain and red indicating a loss. Then they did a genomic analysis on the small nucleotide variants to assess the mutational load in the tumor and the organoid. And they did a 30 signature study, and they found out that, again, there was a high level of concordance, which was seen in both the high level of concordance in the SNVs of the most frequently mutated genes was seen. Now, next, they assessed the response to the radiation and 5-FU and irinotecan in the lab. And the response assessment to radiation was done based on organoid size change after 8 gray of radiation. And they did a change with respect to from day 0 to day 24. So in this patient number 12, there was a very good response which was seen. However, in patient number 14, they saw that there was no great response. The mean difference in size from day 0 to day 24 after 8 gray of radiation was found to be 36.42%, which they kept as a cutoff to demarcate whether there is a response or not, which you can see on this one as the dotted line which has been present. And whatever was below the dotted line showed a good response, and whatever was above the dotted line was not showing a very good response. Same for the surviving organoids. The red ones were not showing a good response. However, the green ones were showing a good response after the radiation. The same thing was done for 5-FU and irinotecan, and they found out that in few patients, there was a very good response to 5-FU, and in few patients, there was a few good response to irinotecan, which can again be seen on the graph by the same 36.42% cutoff line, which they had kept for response assessment. Next, they tried to see the response in the clinics by a radiological response assessment and pathological response assessment. And they found that in few patients, especially like in patient number 5 and patient number 16, which they have put, patient number 5 had a very good radiological response with the tumor no longer seen after neoadjuvant chemoradiation, almost full disappearance of the tumor on the MRI. And in patient number 16, when we do a biopsy post-chemoradiation, we see that the adenocarcinoma cells, which are seen earlier, are no longer seen and only normal variants are seen. Contrary to that, in patient number 10 and patient number 1, which they have put, in patient number 10 in the MRI is showing that there is no marked regression in the disease post-chemoradiation. And in patient number 1, the adenocarcinoma cells can still be seen post-chemoradiation, indicating not a very good response to the treatment which has been done. Then they tried to see, when they combined the three things together, how was the response assessment and how did the patient respond? So like in few patients, like what we saw in the last slide, like patient number 5 and patient number 16, who had a good response, these patients, when they saw in the lab, again, they had a very good response both to irinotecan, 5-FU and radiation. And all the three lines were below the cutoff which they had done. For few patients, there were few things which responded and few patients which did not respond. Like in patient number 8, he had a good response to radiation, but there was not marked response to either irinotecan or 5-FU. In patient number 1 and 10, which was shown in the previous graphs, we can see that there was not response seen to either of the things, whatever was used, and so these patients did not respond very well to the chemoradiation which was given. They tried to plot a graph on how was the response between organoids and what was seen in the clinics, and they found out that actually there was a high sensitivity and specificity to which the organoids match with the clinical response, with a sensitivity of nearly 84%, specificity of nearly 92%, and accuracy of nearly 87 to 88%. So what they concluded was that they have made a living organoid biobank from patients with locally advanced rectal cancer enrolled in a phase 3 clinical trial. These organoids closely recapitulate the pathophysiology and genetic changes of corresponding tumors. They can predict chemoradiation responses of locally advanced rectal cancer, and they present a companion diagnostic and rectal cancer treatment. Thank you.